Assalamualaikum, ladies and gentlemen. We are about to have a class, and I hope all of you can pay attention and take the benefit from this class. Masa sekarang kita sedang menunggu ketibaan doktor, so harap semua can fasten your seat belts and welcome to the
Kau boleh diam tak Faiz?
seminar. Yes.
Kau boleh diam tak Faiz?
Sabi itu. Hai. Haikal. Saya faham. Data doktor dah masuk mampus aku. Alah gang, benda dah rekod dah. Like pun yang bukan-bukan dah. Enjoy je lah. Kau tekan rekod.
Oh ya.
Okay lah. Sementara menunggu ketibaan doktor, jomlah kita berhibur sikit. Jom kita nyanyi sikit. Lagu apa Rugi lah gang. Saya baru nak nyanyi tadi. Tak boleh dengar. Saya biasa kalau saya nyanyi, burung yang terbang tu dia berhenti tau. Tapi macam mana? Tak ada orang nak.
My God Faiz, diamlah.
Okay, hi everyone. Hello,
Yes, sir.
can you all hear me?
Yes, clear.
Yes, clear.
All right. So sorry for the delay. Okay, we can start now.
Hello, can you hear me?
Yes.
All right. Good afternoon, Dr. Arunan and my fellow friends. So for today's seminar, there will be 4 presenters and each one of us will present one topic. And for today, my name is Muslim binti Muzamil and I will present about bronchial asthma. And in this topic, I will present about the definition, epidemiology, causes, pathophysiology, symptom, physical examination, investigation, management, as well as complication of bronchial asthma. So first, let's look into the definition of bronchial asthma. So bronchial asthma is chronic airway inflammation causing increased airway responsiveness that leads to persistent symptoms such as recurrent episodes of wheezing, shortness of breath, coughing, as well as chest tightness. And the one that I bold, which are wheezing, shortness of breath, and coughing, are the common presentation in patients with bronchial asthma. And bronchial asthma is associated with widespread airflow obstruction and often reversible, either spontaneously or with treatment. It is also involved 3 physiological changes, which are reversible bronchiolar muscle spasm, mucosal edema, as well as increased mucus production. For the epidemiology, bronchial asthma is the most common chronic respiratory disorder in childhood, and the prevalence is higher in boys compared to girls. As I stated there, the male to female ratio, the male ratio is 2 and the female ratio is 1, which you can conclude that it is commonly affect the boys. And in Malaysia, Malays have the highest asthma prevalence compared to other ethnicities. And as you can see, 8.1% of cases are from Malay race, and 7.4% for Chinese, and 4.3% for Indian. And for the causes of bronchial asthma, there are lots of causes that can, these causes can be divided into extrinsic and intrinsic factor. So extrinsic factor, when here, the first extrinsic factor is infection. Any infection, can you see the cursor here?
Yes.
So the extrinsic factor are infection, any allergy to foods, exercises can also induce bronchial asthma, any allergy to medication, any exposure to air pollution, smoke or dust, as well as exposure to cold environment. And for intrinsic factor, it is genetic factor, and incidence is higher in child when the first degree relative are asthmatic patient. For the pathophysiology, here, as you can see, exposure to the allergen will then trigger the release of immunoglobulin, and this immunoglobulin will bind to mast cell, and this mast cell will release histamine and leukotriene, which cause bronchoconstriction. It affects the muscle and cause bronchoconstriction. And histamine also act as chemotatic factors, which attracts other cells such as neutrophil, eosinophil, macrophage. So this will lead to inflammation and edema of the airway. So here are the symptoms of bronchial asthma. As I mentioned before, cough, wheezing, shortness of breath, and chest tightness. So all of these symptoms are results from the increased mucus production, mucosal edema, and also bronchoconstriction. So when the patient came to us, we need to ask about the symptom, right? So we need to know the pattern of the symptoms. Is it recurring? Because a patient with bronchial asthma, usually the pattern is recurring and it occurs in several events, which known as episodic, and also it usually occur in daytime. However, for cough, it usually occur at night or early morning. So just remember three patterns for bronchial asthma. It is recurrent, episodic, and daytime. And then we need to ask about the triggering factors. Did the child do any exercises before having the symptoms? Does he exposed to any pollen, dust, or cold weather? Is there anyone in the house smoking? Or we can also ask about the housing condition. Did the family live in the industrial area? So this we need to ask all about the extrinsic factors before. And then for the severity, how do we ask for severities? So first one, we can ask if the child already went to school, then we need to ask about the number of school that he or she missed due to her condition. So and we can also ask about the limitation of activity. Did the child talk in phrases or in words when the symptoms occur, or when the symptoms occur, did the child cannot did the symptom occur when resting, or it occur when only when the child is running? And then we need to ask about the risk factor as well. Ask for any atopic condition such as allergic rhinitis or eczema. And also we need to ask about family history of asthma or allergy, because it will increase the probability for the child to have asthma. And then any previous hospital admission or similar presentation before. And if the patient was diagnosed with asthma before, ask about the current treatment and the control of the disease. Does the asthma is well controlled or partially controlled or uncontrolled? Next, for the physical examination, first from the general examination, we can look for sinuses, or we can look for the sign of respiratory distress such as nasal flarings, expiratory grunting, tachypnea, and also if the patient had already diagnosed with asthma before, then look for Cushing features. It is because of prolonged usage of steroid. And we can also look for condition, the atopic condition, like for dry in eczema patient, we can look any dry or scaly skin. So this will suggest the atopic condition. And for the lung examination from inspection, we can see hyperinflated chest and also Harrison sulcus. Harrison sulcus is the anterolateral depression of the thorax at insertion of diaphragm. I think you can search for the image later, because from explanation it's a bit maybe you don't really know how to imagine that, but just that the rib area, it will be depressed inward. Then for palpation, there is reduced chest expansion and reduced vocal fremitus. And on percussion, it will be hyperresonance. And on auscultation, the patient may present it with vesicular breathing with prolonged expiratory phase, or the patient may have reduced air entry and generalized expiratory rhonchi. So for the diagnosis of asthma, it is based on the symptoms pattern as well as the clinical history and physical finding. So as you can see on the table, there are 4 criteria that we need to check, and which are the duration of the symptoms, number of exacerbation, the interval symptoms, and also atopy or family history of asthma. So if the duration of symptoms is more than 10 days, the number of exacerbation is more than 3 per year, the interval is during play, laughing, or exercising. It is occur frequently. Or there is presence of family history of asthma. And these are the differential diagnoses for bronchial asthma. First is bronchiolitis, because bronchiolitis also present with wheezing, and also there is also presence of coryzal symptoms such as nasal congestion, nasal discharge, and also mild cough. And then inhale foreign body. There is sudden onset of the symptom, the cough, shortness of breath. So we need to know the wheezing, because in inhale foreign body, usually the wheezing is unilateral. And then cystic fibrosis, there will be excessive cough and mucus production. Therefore, we need to ask further about the other symptom of cystic fibrosis, like gastrointestinal symptoms. And pneumonia also presented with wheezing and also nasal congestion. However, in pneumonia, there is high grade fever. However, in asthmatic patient, there is no presence of fever. And then vocal cord dysfunction. So for vocal cord dysfunction,
Hold on. So you mentioned that the way to differentiate pneumonia and asthma is that pneumonia can have fever and asthma don't have fever, right? That's a bit
yes.
misleading. That's a bit misleading, because pneumonia itself, or in other words, infection also can be a precipitating factor for a exacerbation of asthma, or a triggering factor for a exacerbation of asthma. So even a patient with the acute exacerbation bronchial asthma, if the acute exacerbation is caused by pneumonia episode, so patient will have fever as well. What? Correct or not?
Oh, correct.
Yeah. So must see what's the precipitating factor, right? So if the precipitating factor is something else like UTI, right? Like food stuff, allergens, weather, this kind of things, obviously the patient won't have fever. Okay. So, but if the patient comes in with the pneumonia and that's causing the acute exacerbation bronchial asthma, then patient can still have fever. So that's not something that very reliable, what I'm trying to say in other words. Okay. So it doesn't have fever doesn't mean it's asthma, and if the patient has fever doesn't mean it's not asthma as well. All right.
All right.
So same goes for cystic fibrosis. Cystic fibrosis is a chronic condition in which patient can always have some chronic respiratory symptoms. Okay. And like how asthma patient will present with a wheezing episode and rapid breathing and a rhonchi on your auscultation, not necessarily a cystic fibrosis patient can present similarly. So it's totally two different conditions. Of course, you have to consider any diagnosis of respiratory condition with chronic symptoms when a child present with the symptoms suggestive of asthma, because asthma also can have chronic respiratory symptoms. Okay, the chronic asthma, when the patient is not in acute exacerbation, also can have chronic respiratory symptoms depending on the severity of the chronic asthma, whether it's intermittent, mild persistent, moderate persistent, or severe persistent asthma. Faham semua?
Understood.
Okay, continue.
Next, for investigation, first is lung function test. You can look for the peak expiratory flow rate using peak flow meter. It is simple and inexpensive. However, using peak flow meter, it is less reliable than spirometry. So next, we can use spirometry. So spirometry is used to confirm asthma. It can monitor the response to treatment, also measure the severity of exacerbation. Usually, the FEV1 to FVC ratio is less than 80% in asthmatic patients. next is bronchodilator reversibility test. It will improve after a dose of inhaled bronchodilator, which is the FEV1 is more than 12%. And then for blood investigation, you can do a full blood count, which
Okay.
they will.
Hold on for a while. So speaking about spirometry, what kind of, how many types of conclusion can we make from the spirometry? Does anyone know?
If it's obstructive or restrictive.
Okay, very good. So the reason for you to do a lung function test is in any case of a chronic respiratory condition or diagnosis. Okay, and the test will tell you whether it's normal or abnormal. If abnormal, then you have to see whether it's a restrictive lung disease or obstructive lung disease. So bronchial asthma, is it a restrictive or obstructive lung disease?
Obstructive lung disease.
Obstructive lung disease. So how do we differentiate whether it's obstructive or restrictive? What kind of results do you get from the spirometry?
For obstructive lung disease, and there is reduced in peak expiratory flow and show a concave shape.
Okay, what you see is actually the FVC over FEV1, right?
Yes.
The functional volume capacity, FVC, if I'm not mistaken. Then against the forced expiratory volume in 1 minute. So you see the ratio. So if it's more than 1, usually I think it should be obstructive. Or no? Yeah. If less than 1, usually it should be a restrictive, right? And then you have to see the percentage. So these are things that you will see. So never mind. So back to basics now. So when you talk about all this investigation is actually to diagnose asthma, is it?
Also to exclude other differential diagnosis.
Okay, good. So why not you finish first, then we'll talk about it again later.
For blood investigation, first full blood count. It may show eosinophilia, also leukocytosis. And for arterial blood gas, it may reveal hypoxemia if the bronchial asthma already become a complication, which is maybe type 1 respiratory failure. And then imaging, chest x-ray can show hyperinflated lung, also peribronchial thickening. But chest x-ray can also be used to exclude other abnormalities such as pneumonia. And then we can do skin prick test. It's to diagnose atopy and to identify which type of allergen that the patient allergic to.
So asthma is a clinical diagnosis, right?
Yes.
Yeah, so you don't need any investigation to diagnose asthma, yes, but you know that there are a few other conditions that you need to entertain as a likely differential diagnosis because the symptoms are can be the same like asthma. Okay, for example, in a child with a foreign body. Okay, so you must understand the foreign body ingestion, of course, can be something acute. It can be an acute event and leading to choking. And so that is if the foreign body is something that big that obstructs your upper airway, correct?
Yes.
Yeah, but if the foreign body is something that is very tiny, that is getting dislodged and settling in distal airway, so patient may not present with a severe symptoms like choking and a severe respiratory distress, sinus, cannot breathe, those kind of things, right? They can be still stable, and periodically they can come like how an asthma patient will present, like acute wheezy episodes, and then come in and then you give them some treatment as if like it's asthma. Then they can improve and they can go back, and after some time they can present with wheezy episodes again. Okay, this also can, what I'm trying to say is that, so the foreign body injection also can present like this, in a long-term chronic respiratory symptoms manner. Okay, don't always think that, okay, foreign body injection means patient must come with choking, severe respiratory distress until like in a dying situation. So always must tell yourself that it can present like asthma also, right? So that's why you have to do a imaging like chest X-ray for a child who's coming in and newly getting diagnosed as asthma, because chest X-ray also will help you to rule out foreign body if the foreign body is something that is imaginable, something that's really opaque. Yeah. Okay, continue.
Next is principle of management. First, we need to assess the asthma severity or newly diagnosed asthma, and then choose the preventive treatment. Next, to assess the asthma control in 4 to 8 weeks, and also did a stepwise medication, and lastly, to monitor the asthma control. This is how we evaluate a newly diagnosed asthma. We can say that the patient might have intermittent asthma or persistent asthma. And then persistent asthma also divided into 3: mild, moderate, and severe. So if it's intermittent, then the daytime symptom is less than 1 per week. The nocturnal symptoms is less than 2 or similar than 2 per month. And then there's no exercise-induced symptoms, and there's also brief exacerbation. And if it's persistent asthma, and if it's mild, the daytime symptom is more than once per week. The nocturnal symptoms is more than 2. The peak expiratory flow rate more than 80%, and it is exercise induced. For moderate, there is the daytime symptoms is daily, and also the exacerbation affecting the sleep and activity for more than twice per month. And if it's severe, it occur daily. The symptoms occur daily, and it's also affecting the sleep and activity frequently. And the peak expiratory flow rate is or the FEV1 is less than 60%. Next is to assess the severity of acute asthma exacerbation. There are 9 parameters we need to ask about the breathlessness, if it's occurred during walking or at rest, if the patient talks in sentence or phrases or unable to speak, and then the respiratory rate, is it normal or mildly increased, markedly increased, and then the use of accessory master, if there's presence or not, and then wheezing, if there's a noisy breathing or not. Also check for the oxygen. If it's less than 92%, then it considered as severe or life-threatening. And then for pulse rate, is it increased or reduced? And also peak expiratory flow rate. After the initial bronchodilator, does it increase or not? So this we can conclude if the patient had a mild exacerbation or moderate, severe, or life-threatening. And this diagram is the algorithm for the long-term management of asthma and the management of acute exacerbation. So for the left diagram, it is for the long-term management of asthma. As I explained before, we need to assess about the if the patient had intermittent or persistent asthma, right? So if the patient had intermittent asthma, then we give intermittent short-acting beta agonist. If it's mild persistent asthma, then give a low dose inhaled corticosteroid or a leukotriene receptor antagonist. If it's moderate persistent asthma, then give moderate dose of inhaled corticosteroid. And if it's severe, then we need to refer specialist, give a moderate dose of inhaled corticosteroid or high dose of inhaled corticosteroid. And if if the asthma is moderate, then we can change the treatment again to moderate dose. If the asthma become mild, then change to low dose inhaled corticosteroid. For the acute exacerbation of bronchial asthma, after we assess the severity, if the severity is mild, then give a nebulized salbutamol or MDI salbutamol, and then review after 20 minutes. If there is improvement, then observe for 60 minutes after the last dose, and there is no other complication, then discharge with a long-term treatment and asthma action plan, and give a short course of oral steroid and regular bronchodilator, as well for appointment early TCA 2 to 4 weeks. But if it's not there's no improvement after 20 minutes, then we can treat as moderate exacerbation to give a nebulized salbutamol via face mask or MDI salbutamol 4 to 6 puff, and then observe for at least 60 minutes after the last dose. If it's improved, then similar to mild exacerbation just now, the discharge, give appointment, give a short course of oral steroid. But if there is no improvement, then patient need to be admitted. And these are the list of the medication that been given to the patient. And then continue the observation and review the patient back again. These are the complications of bronchial asthma. So bronchial asthma can cause pneumonia, lung collapse, pneumothorax, as well as type 1 respiratory failure. All of these are due to lung damage or weakness in lung tissue because of bronchial asthma. So I think that's all from me.
Okay, is there any question from anyone?
I have a question.
Yes.
In the ward, why we usually diagnose asthma in patient more than 4 years, and if we under than 4 years, we usually diagnose the patient as pneumonia first.
Okay, I think your
Um,
understanding is wrong. It's totally two different things. I think your question, you wanted to ask something else, right? Probably you wanted to ask why a older child diagnosed as asthma and a younger children diagnosed as something else like viral disease, multi-trigger disease. Is that a question?
yes, doctor.
Pneumonia is totally different entity. There's nothing to be confused with asthma. Pneumonia is a infection, it's a lung infection. There's no question about it, right? So it has nothing to do with the age. Pneumonia can happen in any group of patient, be it very young infant or newborn, as as young as a newly born, or as old as like 70, 80, 90 years old also. So I think there's no question there, right?
Yes, doctor.
Yeah.
Clear
So
about that.
asthma. Okay, before we speak about asthma, you have to know there's something called hyperactive airway disease, correct? You all know aware about this hyperactive airway disease? Have you all heard about this term? Sorry? In textbooks, right? So in your textbooks, I'm sure there's this term, isn't it? Hyperactive airway. So basically, asthma is a hyperactive airway, all right? So only when, to answer your question, when you talk about in very young children, like infants and toddlers, it's not that you cannot diagnose asthma in this age group, okay? Asthma is not age specific, okay? Asthma can be diagnosed in any age group. But you got a point there when you say in a younger age group, you have to be more careful when you diagnose them as asthma, right? With the history, with the given history, if you are very confident that this is asthma, as patient fulfill all the criteria, then you can confidently diagnose asthma even in a 7, 8, 9 months old, 10 months old, 11 months old, 1-year-old child. So in other words, what I'm trying to say, again, asthma is not age specific. Okay. But why did I say that you have to be a bit more careful when you diagnose asthma in smaller children like infants and toddlers when compared to older children who's around the age of 4, 5, 6, 7 years old? That is because due to your embryology of the respiratory system, your lung development only completes at the age of around 4 years old. Okay, because if you talk about the lung development, there are 4 stages, right? If you don't know, go back and read on lung development. Okay, there are 4 stages like alveolar stage, saccular stage, precanalicular stage. Okay, those kind of things, right? So the age of lung development only complete around late 3 to 4 years old. That's the reason why when the lung maturity has not been completed, in that interim period, the child is still bound to get a hyperactive AV. Okay, for example, when a child exposed to URTI, and certain children have this predilection to develop viral-induced wheezy episodes. They have this tendency to develop wheezy episodes. But if this wheezy episode is due to viral infection like URTI, then we call it viral-induced wheeze. The thing about viral-induced wheeze is that in between the episodes, they will be completely well. Okay, they won't have any interval symptoms like intermittent asthma. What is different about viral-induced wheeze and intermittent asthma is that the things that make the child to have wheezy episodes is almost all the time only viral infection, meaning when the child has URTI symptoms. Otherwise, all this cold weather, climate changes, dust, cold beverages, allergens, all these won't trigger the child to have wheezy episodes. Otherwise, I mean, on the other hand, in asthma patient, their triggering factors is one of it, even though it's URTI, but they also have many other triggering factors. Okay, they also get triggered to develop exacerbation due to other factors like what it was mentioned in the lecture just now by your friend. Okay, so that's the reason why you have to be careful when you want to diagnose asthma in a smaller children, because it could be something that related to the immature lung. So in which, when they develop all these viral-induced wheeze and due to viral infection, they develop wheezy episodes. But this group of children, as they grow, okay, when they reach the age of like 4 or 5 years old, when the lung maturity has been completed, they don't develop the wheezy episodes anymore. So that is not asthma. Okay, in asthma, the children, even though they are bigger ones, even after the lung development has been completed, they still can develop this acute exacerbation of bronchial asthma. That's the two different thing about viral disease. Viral disease, usually bigger children, they don't, even though in a smaller age, like when they're infants and toddlers, when they develop viral disease, but eventually as they reach the age of 4 or 5 years old, they don't develop it anymore. So that is not asthma. Okay. So to answer your question, it's not that you cannot diagnose asthma in the young children. You can, but given the explanation that I gave just now, you have to be a bit more careful when you diagnose asthma. If you're not sure, if you're worried, then you can follow up the child and see whether the child develop more features to suggest that this is asthma. Okay, faham?
Oh, faham, Doktor.
Okay, if there's no other question, I think we'll move on to the next lecture.
Can you hear me?
Yes.
Can you see the slide? Nampak ke?
Yes.
Okay. good evening, good afternoon to all of the group members as well as Doctor. So my name is Nusa Zahira Muzaki, and today I'll be presenting regarding the topic of bronchiolitis. And here are the contents for my presentation today. So without further ado, we will start with the introduction part. So basically, bronchiolitis is a disease of small bronchioles with increased mucus production and occasional bronchospasm. Sometimes it can lead to airway obstruction. And this disease usually it affects children less than 2 years old, and the peak incidence usually occur in children of 3 to 6 months of age. And this is one of the most common cause of lower respiratory tract infection in the first year of life, along with bronchitis and pneumonia. And usually for bronchiolitis, the disease is generally a self-limiting condition within a period of 2 weeks, but it can be if it's not treated or if the patient or infants develop a severe manifestation of disease, then it can be life-threatening. So for the epidemiology, bronchiolitis is a leading cause of hospitalization in infants, about 2 to 3% of them, and the peak incidence usually occur in winter months, where the causative agents are the most active. But in Malaysia, it occurs throughout the year. And in Malaysia, although it occurs throughout the year, it can the peak of incident occur in several months, such as November, December, and January. So usually in bronchiolitis patient, by their first year of age, over 60% of children have been infected, and by 2 years of age, over 80% have been infected. Just to show that the disease is common, and also the disease occur more frequently in males rather than in females. Next is regarding the cause and risk factors for the disease. For the causative agents, for bronchiolitis, it is predominantly a viral disease, meaning that it's caused by the virus. And the most common pathogen is respiratory syncytial virus or RSV. Other viruses that can lead to this disease is rhinovirus, influenza virus, human metapneumovirus, and also adenovirus. So for RSV, how it is being transmitted is by droplet or direct contact of the respiratory secretions. For example, via fomites, via aerosols, or via contact with six people. For example, if the disease, the RSV infection, is very highly contagious in adults as well as children. The difference is that in infants, their immune system, their immune defense is not developed as adults. So when they have the disease, the clinical manifestation will be severe, whereby the adults they might have only mild symptoms. So for risk factors, we can divide it into host and also environmental factor. So for host, the factors are prematurity, congenital lung disease, congenital heart disease, as well as immunocompromised, and the age of the infant is usually less than 3 months, and also neuromuscular disorder. For the risk factor indicates severity of the disease, not saying that this patient if you have this, you will get the bronchiolitis. It's just to say that if the patient have all of these factors and they have the bronchiolitis, the manifestation of the disease will be severe compared to other infants. So for environmental factor, there are smoking. Smoking might trigger or worsen the condition, and crowded environment, it's easy for the disease or the virus to be spread between the community, as well as winter months. As I mentioned just now, the virus prevail in this period of time. So next is pathophysiology of the disease. So as I mentioned, the bronchiolitis is a lower respiratory tract infection, but the virus first will reside in the upper respiratory tract first. For the virus, the disease start with inoculation of the respiratory tract by the virus. So what happened is that the virus will first infect the epithelial cells of the nasopharyngeal cells, which then will lead to presentation of rhinorrhea or nasal congestion. So after a prolonged period of 4 to 5 days, due to the immature immune system of the infants, they cannot defeat or they fail to clear the virus. So the virus will start to replicate and transfer to the lower respiratory tract. So in the lower respiratory tract, again, similar, it will infect the epithelial cell of the lower airway, causing inflammation. And then the features will be different. The child will start to present with coughing, tachypnea, lethargy, and poor feeding, as well as if it's severe, it can cause dehydration. And for the acute cause, after 3 to 7 days after the manifestation of the lower respiratory tract symptom, due to the small airway diameter, we need to understand that this disease usually occur in infants. So their diameter, their bronchial diameter is very small. So after that, this virus will infect again the superficial layer of the epithelium, but then it can cause again inflammation. Then those inflammation will lead to peribronchial edema and also mononuclear infiltrate. And this inflammation can also stimulate upregulation of the goblet cell, leading to excessive mucus production. All of this is a pathological mechanism that can cause obstruction of the lower airway. So, sloughing of the epithelium will cause various degree of obstruction in the distal airway. In such, if you can see from the picture at the left bottom, so here, what I mean by that is that just now I said that the the sloughing of the cell along with excessive mucus production. You can see my cursor, right? Okay, the yellow thing here is the mucus. So the sloughing epithelial cell along with the excessive mucus production will cause, as you can see, cause accumulation of the debris here in the distal airway. So what happened is that this obstruction is supported by the pathological mechanism of the disease itself, as well as the anatomy of the bronchial. So as mentioned that the bronchial is small diameter, and also here there is a peribronchial edema that will further narrow the airway. So you can imagine if the airway is narrow, it's already small, then you make it narrower. So when it accumulates, so it cannot pass the air, the volume of air that pass through will be lesser. So that is to definitely cause the obstruction. So here the picture here just to show the difference between the normal bronchial as well as the disease bronchial. A similar mechanism as well. So next, the obstruction just now, there are two types. We can divide into either partial or complete obstruction. So the partial one, we call it as dynamic obstruction. So this dynamic obstruction in the bronchi is like a one-way valve. When you during expiration, the intrathoracic pressure will the negative interthoracic pressure will allow the airway to open. So the air can pass the obstruction. It's not if the partial mean that there is still a way to pass through the alveolar. So but when we expire, the airway will start to close. So the air will get trapped inside. So this will cause the alveolar to become overinflated with trapping of the air. And also the wheezing sound is caused partially again just as I mentioned due to all the pathological mechanism, the edema and also the sloughing cell that can cause the narrowing. Then that will produce the sound, along with the bronchospasm due to inflammatory response. And for the complete airway obstruction, here is when the alveolar start to stop ventilate, which means that it's completely obstructed. And when the all of the gases are absorbed into the circulation, and the alveolus will start to collapse. So this will cause atelectasis. Atelectasis is what we call as a partial or partial collapse, collapse of the part of the lung of the entire lung. So you can see here, for example, here the obstruction is here, so this is complete obstruction. So the air cannot enter because they cannot ventilate, right? So the trapped air in here will start to be absorbed, and then the alveolar will collapse. Again. And this obstruction will lead to ventilation perfusion mismatch, and this will cause either hypoxemia or reduce in oxygen saturation. And if it's not treated and it becomes severe, it can the disease progress. It can lead to hypercarbia or hypercapnia, increase in CO2 or type 2 respiratory failure. And also the BQ mismatch is the one that contribute to tachypnea, the patient to be tachypneic. So for the resolution of the disease after the acute onset, the infant usually recovers spontaneously with supportive measures. And as I mentioned, it takes around 2 weeks for it to be resolved completely. So next is the clinical feature or the symptoms of the disease. So the early symptoms is coryzal symptoms such as nasal congestion and mild cough, as well as low-grade fever. So I've mentioned just now, the virus is start to infect the upper respiratory tract. So the first symptom, the first manifestation is upper respiratory tract symptoms. And after that, for a few days after the infection, the infant will start to have persistent cough, dyspnea, noisy breathing, wheezing, or difficulty feeding. This difficulty feeding is due to nasal congestion as well as the tachypnea. So it's hard for them to eat. And for the apnea, I put it quite a distance there because for this apnea, it's usually complication for bronchiolitis. But sometimes it can be the first clinical manifestation of the disease itself. It's just that when I say first manifestation means that it is not preceded by upper or lower respiratory tract symptoms. So that's why I put it in the symptoms. So next, regarding the clinical features. So generally, we can see that the patient or infant is having a dry, wheezy cough. He or she is tachycardic. There might be cyanosis or pallor if it is severe enough. And for inspection, we can see hyperinflation of the chest, whereby the sternum is prominent. Also, you can see that the liver, or through palpation, you can feel that the liver is displaced downward. So there is if the infant is having a severe respiratory distress, then the patient might come with tachypnea, subcostal and intercostal recession, increased respiratory effort, nasal flare, and also excessive use of accessory muscle. And for percussion, in the hyperinflated lung, you can hear that it is hyperresonant. So for auscultation, what we can hear is fine and inspiratory crepitation and prolonged expiratory phase. Sometimes we can hear wheezing, and sometimes we cannot appreciate that, and also reduce breath sound. So next is regarding investigation. So for bronchiolitis, diagnosis is made clinically on the basis of true history and physical examination. So what it mean by here is that there is no diagnostic test. So you cannot say that there is test to diagnose the bronchiolitis. There is test to confirm. There is no test to diagnose. So for routine laboratory tests, usually it's not required to confirm diagnosis, but we can still do the FPC, like to check for leukocytosis to see if there is infection by the bacterial infection, or there is a co-infection with bacteria, and also ABG can be done in order to assess severity of the disease, like hypoxemia, hypercapnia just now. And also the important test in bronchiolitis that we need to do is, the first one is pulse oximetry. This one is to assess oxygen saturation, because in bronchiolitis, if the patient oxygen saturation is less than 93%, then we need to supply oxygen. And for chest X-ray, it is used to detect lung or heart abnormalities, because sometimes the patient might have a congenital disease, and also to exclude other causes. So usually for chest X-ray in bronchiolitis, there is hyperinflated lungs, where I will show just after this. And for the third one is nasopharyngeal swab for viral testing. So this one is to confirm diagnosis and also detect the causative agents. So here is the picture of the chest X-ray. As you can see, the chest radiography reveal lung hyperinflation with a flattened diaphragm, and also bilateral atelectasis in the right apical and also left vessel region. So next, moving on to the differential diagnosis of bronchiolitis. So for this differential diagnosis, all of them have similar characteristic, which is all of them can present with wheezing, because wheezing is the most common presentation for bronchiolitis. So the other causes that might that also have wheezing might present similarly. For example, the condition is asthma, pneumonia, viral-induced wheezing, cardiac failure, exacerbation of chronic lung disease, gastroesophageal reflux, and also foreign body aspiration. For asthma, it is difficult actually to differentiate based on physical examination, but we can differentiate these diseases based on first age of presentation. Usually bronchial asthma in older patient, older children, whereby bronchiolitis affect children in less than 2 years of age. And also there is absence of personal or family history of asthma or atopic condition like eczema or rhinitis. And for pneumonia, usually wheezing is less common in pneumonia, but as I mentioned, pneumonia is also a common lower respiratory tract infection in children. And other than that, for viral wheezing, viral-induced wheezing is quite similar presentation with the bronchiolitis. How we can differentiate it is by onset of the symptoms. For example, in bronchiolitis, it took days for the symptom to develop, but for viral-induced wheezing, the symptoms can occur within hours. So for the cardiac failure and chronic lung diseases, as I've mentioned, it's related to the risk factor. And for gastroesophageal reflux, usually the wheezing tend to be chronic or recurrent, and also the patient might have history of frequent emesis. And for foreign body aspiration, it also again can cause acute or chronic wheezing, but we need to look back at the history, also the chest X-ray. So next is regarding the complications of the disease. So I've mentioned just now regarding the apnea. It is one of the complications, but it can be the first clinical sign. And for the respiratory failure, I've mentioned just now during the pathophysiology, it can either cause type 1 hypoxemia or type 2 respiratory failure, which is hypercapnia. And the third complication that bronchiolitis can cause is secondary bacterial infection. Because this happens because of when there is infection, then there will be reduced in the immune protection. So it is more, the infant is more susceptible to get secondary infection. The most common secondary bacterial infection associated with bronchiolitis is otitis media. So for bronchiolitis, the fourth complication is bronchiolitis obliterans. So this is very rare. It is permanent lung damage due to a long-term inflammation and scarring. And this problem or this disease is usually caused by adenovirus rather than RSV. So in terms of the management, for management of bronchiolitis, as I've mentioned, is mainly supportive, but we can divide it into non-pharmacotherapy and pharmacotherapy. So the first one, for non-pharmacotherapy, first we need to do to monitor the respiration, whereby we need to perform we need to check for the arterial oxygenation by the pulse oximetry, and it should be maintained more than 93%. And if it is necessary, then we need to deliver supplemental humidified oxygen via nasoprong or oxygen mask. And if the patient is having a severe condition or severe respiratory distress, then we might perform mechanical ventilation. And the second one is nutrition and fluid therapy. So in patient with mild symptom or mild or moderate symptom, usually we provide small feeds, like small frequent feeds to the infants, but if the infants refuse feeding, then we might need to use nasogastric feeding. And also we need to give IV fluid in case the infants have severe respiratory distress, cyanosis, and also apnea. And for pharmacotherapy, mainly the medications are used to manage the symptoms. For example, we use 3% saline solution via nebulizer in order to increase the mucus clearance, to reduce the wheezing as well as the breathing difficulty, and in order to reduce hospital stay. And for fever control, usually we give paracetamol, acetaminophen, or ibuprofen. And for antibiotics, it is not recommended because, as mentioned, it is predominantly a viral disease. It's bronchiolitis caused by virus, so you don't have to give antibiotics. But it is recommended in infants with recurrent apnea and circulatory impairment, possibility of septicemia, acute clinical deterioration, high white cell count, and also if there is proliferative changes in the chest X-ray. Might indicate like co-infection with bacteria. And the other thing is there are some therapy that are not recommended to treat bronchiolitis because there is no clear benefits or less evident regarding the benefits, such as physiotherapy, inhaled steroids, and also inhaled beta-2 agonists or bronchodilator. So here is the management for hospital admission. So there are some patients or infants that need to be admitted immediately to the hospital, and those patients are the one that is less than 3 months, toxic looking, if they are severe chest recession, if the central cyanosis is already present, difficulty in feeding, there's presence of apnea, as well as the oxygen saturation is less than 93%, and also the patient has risk factors. So then we need to admit to the hospital for further management. So the last part of this presentation is prevention of prophylaxis. So basically, the first one is hand washing and routine infection control practices in order to prevent the infection as well as prevent the reinfection. And also we have to, in patient with high risk factor, we need to give palivizumab prophylaxis. It is an monoclonal RSV specific antibody. And usually it is given intramuscularly during peak season because it is a passive immunization. So you only give it when the season is peak, for like winter months. For the infants with high risk factors, such as infants under 2 years old with chronic lung disease, very low birth weight, or having congenital heart disease. Other than that, also we can give immunization with influenza vaccine for children of more than 6 months, and it may prevent influenza associated disease, because for bronchiolitis it also can be caused by adenovirus. So I think that's all from me. Is there any question? Okay. If there's no question,
Okay. Is there any question for anyone? Okay. Any question when you come across the case of a bronchiolitis in the ward that you're not sure? You can ask now also. So, don't have. So what's most important here is that must know how a child with bronchiolitis can present. And of course, that presentation can be mimicked by few other conditions as well, you know, like asthma and pneumonia. So what's important here is that to be able to differentiate, okay, bronchiolitis with asthma and pneumonia. Okay, because all of it are clinical diagnosis. Okay, there's no gold standard laboratory investigation that you can do to confirm the diagnosis. Okay, so the only way you can confidently diagnose is by having a good knowledge, by seeing a lot of cases of bronchiolitis, pneumonia, and asthma, because these are the cases that we can, we as a doctor cannot run away from. Right? So, so be aware of those differences. Okay. Okay, let's move on to the next lecture.
Okay, good evening, Dr. Arunan and my classmates. My name is Shahida Atira. I'll continue our seminar session with pneumonia. So in my seminar, I'll give some introduction. We'll learn about the etiology and pathophysiology of pneumonia, symptoms and signs of pneumonia, the complication, of pneumonia, how to investigate, and how do we manage pneumonia. So let's first start with the introduction. So according to WHO, that pneumonia is a form of acute respiratory infection that affects the lung. We know that our lung is made up of alveoli. So when we breathe in, the alveoli will be filled with air. However, in person with pneumonia, their alveoli will be filled with either pus or fluid. So it impairs the gas exchange, causing the patient to have shortness of breath. Epidemiologically, pneumonia has highest incidence rate in infancy, and it remains relatively high in children. So what causes pneumonia? The pathogen can be either virus or bacteria. That's the most common. However, fungus can also cause pneumonia. So for virus, common causes is respiratory syncytial virus, RSV. However, for bacteria, because there are many bacteria that can cause pneumonia, we can predict them by dividing it according to age group. So if it's newborn, the common pathogen would be group B Streptococcus, Escherichia coli, Klebsiella species, and also Enterobacteriaceae. Infant 1 to 3 months old might be Chlamydia trachomatis. For preschool age, usual organism would be Strep pneumoniae, Haemophilus influenza B, and also Staph aureus. And if it's school age patient, might be Mycoplasma pneumoniae or Chlamydia pneumoniae. So how does pneumonia occur in a person? Usually our respiratory system is blessed with their own defenses. We have the cough reflex, we have the mucociliary cell, and also macrophage resides in the respiratory system. Not to forget our antibody. However, in children with maybe there's impairment of this mechanism. So when the bacteria or virus enter the lung, they can infiltrate and starts to proliferate in the lung. So our immune system will be triggered. There will be many cytokines released, causing inflammation at the alveolar. So what happened next? The alveolar wall starts to be leaky, as well as the pulmonary capillaries. So the alveoli will start to be filled with fluid, pro-inflammatory molecules, and pathogens. So that's how gas exchange will be impaired. So because of that, patient can come to us with a first fever due to infection and also rapid and shallow breathing. These are most common chief complaint lah. Other than that, patient can also come with cough, a runny nose and lethargy. In younger, like newborn, they might have poor feeding, started to be restless and irritated. In school age, not school age lah, if the pneumonia is quite severe, they started to infect the pleural. So the patient might come with pleuritic chest pain, neck stiffness, and also abdominal pain. So what are the physical findings that we can find? Usually for pneumonia, it will show signs of lung consolidation lah. So on inspection, the child might show signs of respiratory distress. We can see they are tachypneic, nasal flaring, and also chest ingrowing. In baby, they might started to grunting, become cyanosis, or we can see that they are air hunger. So on palpation, there will be reduced chest expansion, dullness in percussion, and also on auscultation, there might be coarse crepitation. Now that we already know the patient, the sign and symptom, how do we assess the severity? For severity, we divide it into age group, either age less than 2 months or between 2 months to 5 years old. So for less than 2 months, there's no severity lah. Less than 2 months is already severe. So patient, we can see that they have severe chest indrawing and also tachypnea. If 2 months old to 5 years old, if it's tachypnea only, so patient might have mild pneumonia. If it involves chest indrawing, they are already in the severe pneumonia. So I hope by now you already know what is chest indrawing. Normal person like us, usually when we inhale, our chest will expand. However, in chest indrawing, the chest will goes in during inhalation. And then we might want to see a little bit on the definition of tachypnea according to age. This is taken from Page Protocol, the 4th edition. So less than 2 months age, tachypnea is more than 60 breaths per minute. 2 to 12 months age, more than 50 breaths per minute. For 12 months to 5 years age, it is more than 40 breaths per minute. Then a little bit on the complications. Relating back to the pathophysiology because of the leaking of the capillary wall, leaking of the alveolar wall. So the patient might come with parapneumonic effusion whereby the fluid already enter the pleural space. And then empyema when the pleural effusion become infected, septicemia, and also lung abscess. So now that we already know the sign and symptom and also complication, let's start to investigate. So first, we might want to do chest X-ray. So in chest X-ray, we can see either patchy infiltration. We can also look either the patient is having bronchopneumonia or lobar pneumonia. So if bronchopneumonia, usually it the patchiness is at the bronchus area. If lobar pneumonia, the infiltrate will be seen on the lobes. And then for full blood count, you want to see specifically on the white blood cell count, whereby if it's increased with predominant polymorphonuclear cells, it might suggest bacteria in origin. However, if it is leukopenia, it might suggest viral cause. Then for blood culture, this is not routinely done. However, we do blood culture if the patient does not respond to first-line treatment to determine etiology. And then the fourth one would be pleural fluid analysis if the patient comes with parapneumonic effusion. So if there is significant pleural effusion, diagnostic test might be helpful lah. And then serological test, this is also not routinely done, performed only when we suspect atypical pneumonia. Okay, so that's all for the investigation. Now let's look on the management. So not all patients with pneumonia need to be admitted to the ward. Some can be treated as outpatient. So for hospitalization hospitalization, these are the criteria taken from the PITCH protocol. Usually, children aged 3 months and below, regardless of severity, if they have fever more than 38.5 degrees Celsius, they refused to feed and started to vomit. If there is fast breathing with or without cyanosis, associated systemic manifestation, failure of previous antibiotic therapy, and also recurrent pneumonia, or the patient might actually have a severe underlying disorder, for example, the immunodeficiency. So if the patient is admitted, what we will do is actually we'll give antibiotic. The first line treatment would be beta-lactam. And then if the patient did not respond, we'll give a second line, cephalosporin. If the infected agent is actually mycoplasma or chlamydia, we'll give macrolide instead of beta-lactam. Other than antibiotic, we can give supportive treatment. There are 5 criteria here. First, for fluids, we don't actually give fluid if patient is having severe pneumonia because there will be increased secretion of ADH. So if we give fluid, we might overhydrate the child. And then we will give oxygen to the child and always maintain more than 95% SpO2. Because some of the patient might come with coughing, right? We actually don't give cough medication to the patient because if we suppress the cough, it interferes the airway clearance. So we don't want that. We actually want to encourage the patient to cough. And then we give some paracetamol for temperature control to reduce discomfort from symptoms. And lastly, chest physiotherapy. This is to assist in the tracheobronchial secretion. However, this is not routinely done. There's no evidence that this is routinely done. And then for outpatient management, for patient with mild pneumonia, we can prescribe oral antibiotic. Just now we already learned about the predictor pathogen in different age group. So based on that, we can give antibiotic. And don't forget to educate educate the parents regarding management of fever, how to prevent dehydration, and to identify signs of deterioration. So if the condition worsen, the parents need to bring back the children for reassessment. I think that's all from me. These are my resources.
Okay, any question from the crowd to the presenter? Okay, if there's no other question, we will continue with the next slide before we wrap up regarding the 4 topics. Keep it to the last. Oh, the next topic is AGE. So I think in that case, we will wrap up the first three topics first because it's all interrelated, right? Then we will move to the last topic. Okay, so we have heard about bronchial asthma, you have heard about acute bronchiolitis, and you have heard about pneumonia. So I'm sure all of you will have some kind of confusion among these 3 topics. Okay, when you see patients around in the ward, you come across these 3 cases. Okay, I'm sure in terms of from starting from the history and then physical examination, okay, going on to the investigation and subsequently the management part. Okay. there might be some confusion due to the overlaps, right? So this is the time for you to ask. I'll try to answer as much as I can. Okay, we can spend around 15 minutes here before we go on to the last topic. Come on. Any question will do. So we have minus me 34 participants here. Takkan satu soalan pun tak ada. Or everything is clear. No question to ask. Okay, so if no question to ask, then it's my turn to ask you all the question. Okay, sure, no question, huh? Okay, Muslina. Sorry, Musliha.
Yes.
Can you unmute yourself?
Yes.
Okay. How do you differentiate bronchiolitis and pneumonia?
Bronchiolitis is usually occur. The onset is not rapid, and it is a viral infection. However, for pneumonia, it can be both viral infection as well as bacterial infection.
So in terms of presentation, how do they differ from one another? What are the differences from the history? Okay, what do you hear differently from the mother of a child with a bronchiolitis compared with from the mother of the child with a pneumonia? What are the differences they can notice from the history?
From the history, for bronchiolitis, the patient may be presented with a dry, wheezy cough. However, for pneumonia, it can be presented with a cough with it is a product cough.
Okay, not a great difference. Anything else? Afika, do you want to try? Afika presented already. Afika presented, right? No. So maybe Afika want to try, unmute yourself and answer. Afika, dah tidur. Afika, do you want to answer? My question was how to differentiate bronchiolitis from pneumonia. So starting with the history, what kind of differences that you can get from the parents of these two children? One with pneumonia and the other one with bronchiolitis.
By using auscultation?
History. Cepat sangat Afika dah unmute balik. Mute balik. Having discussion over there ke?
For
No need to discuss.
bronchiolitis,
Who's answering? Afika.
yes.
Yeah, go
For
on.
bronchiolitis, the patient will come with sore throat first.
Okay, never mind. Okay, so as you all heard in the lecture just now, okay, bronchiolitis is viral etiology in origin, right? Does everyone agree with that?
Yes.
Yeah. So viral in etiology. So usually it's not a must. This is not a must. Okay, so please get me right. Usually patient will come with coryzal symptoms. Coryzal symptoms means cough, runny nose, those kind of things. And within a short period of developing these coryzal symptoms, patient will develop rapid breathing. Okay, due to the lot of secretion producing nature of the virus. Okay, and as was mentioned in the pathophysiology part by your friends, in children, anatomically, naturally, the airway is smaller in caliber, right? Excuse me. Right?
Yes.
Compared to that. So for that reason, and at the same time, as I said earlier, due to the virus can produce a lot of secretion, it may cause some obstruction. So when there's obstruction, there will be increased airway resistance. So the child will struggle to breathe. So that's the reason why the child will develop rapid breathing. But despite all this, the child will be still active, cheerful, can still feed orally. The child doesn't look sick, like how a pneumonia child can present. Again, I'm not saying pneumonia child must present sick. A child with pneumonia with a bacterial or bacterial origin can be sick, but not necessarily. All right. On top of that, child with pneumonia can have fever. They will be more sick looking. They can be lethargic. They may tolerate feeding poorly. Okay. But on the other hand, as I said, it's not a must. The patient can be still active and well upon presentation, even with pneumonia, right? So of course, you can differentiate bronchiolitis from pneumonia based on your radiograph investigation and all that. Okay.
Doctor, so you said just now bronchiolitis, usually the patient will appear active, right?
Yeah.
So it usually be confused with atypical pneumonia. Is it that?
Okay. Again, that's why you have to look at the whole picture. What's the age of the patient? What's the history like? Okay. But atypical pneumonia, not necessarily patient will come with a short history of symptoms followed by a rapid breathing. Okay. Again, this atypical pneumonia usually happens in school-going children. Okay. Because of the exposure at the school and all that, right? So it happens in older children. Okay. Again, it cannot be 100% just with the virtue of the history and your physical examination. Okay, this is pneumonia. This is 100% atypical pneumonia, and this is atypical or 100% other bacterial pneumonia. Okay, this child is 100% bronchiolitis. It cannot be 100% sure, right? You can just come to a fair conclusion, okay, by putting all together your examination, your history, examination finding, investigation, and come to conclusion that okay, most likely this could be bronchiolitis, most likely this could be pneumonia, most likely this could be atypical infection. Okay.
Okay, doctor, thank you.
All right. So
Doctor, I have a
on,
question.
yeah.
Can we, so doctor, can we say that the pneumonia more present, can present more higher grade fever, right? And then the bronchiolitis, low grade fever.
No, that's not a reliable identifier. No, the answer is no. Okay. Can you hear me?
Yes, Doctor.
Okay. So if some of you has been with me during the bedside teaching, okay, and I would have taken my session particularly about the history taking. Have you all? Any one of you here? Not yet. Or you all are totally new group.
Totally new group, Doctor.
Okay. So I would have stressed there lah. So I usually will stress there. What are the histories that you all must focus to differentiate? Okay, among your differential diagnosis. Never mind when you all come to for the bedside teaching, we can go through that again. Yeah. So right. Okay. So when you suspect asthma, so your history have to be very detailed, right? It may be the scenario will be such that the child present with some symptoms for the past few days. Okay, don't be too comfortable with just that 3 or 4 or 5 days, whatever number of days of history that the parents are volunteering to you. Okay, you must probe a little bit more to find out if the child has been really well before that, or the child's current presentation is just another repeating presentation. In other words, what I'm trying to say is the child might have been similarly sick for many times before. If you don't ask, the parents won't volunteer because their concern is just the current presentation. Okay, so it's your job to find out if the child has been having previous many undiagnosed exacerbation for which the child has been presenting to clinic Satan for NAP, and then some ED for NAP, and then seen and discharged. Okay, so it's your job to find out and tie the knots together if all the previous presentation is related to the current presentation. Usually this can be the scenario if your child is coming in with the newly diagnosed asthma. Okay, those things cannot be missed. It'll be totally different for a child who doesn't have asthma currently, who's just coming in for pneumonia. Okay, the child might have had a previous history of hospitalization, but not necessarily. That could be a totally isolated episode of illness. Okay, in which the current presentation has no connection to the previous presentation. Okay, it can be still possible, but a child can come in with first episode of pneumonia in which the child shouldn't have any previous episodes of presenting to healthcare frequently because being unwell. Okay. Okay, before we wrap up, I would like to introduce this one term which is called as recurrent pneumonia. Have you heard of this recurrent pneumonia? Have you all heard about this term, recurrent pneumonia?
No.
Okay. So recurrent
Yes,
pneumonia
doctor.
means once a child has 2 episodes of pneumonia, no time frame, okay, in lifetime, that's already considered a recurrent pneumonia. That's a bit unusual for someone to develop 2 pneumonia in a life. Okay. So you have to find out whether this is recurrent pneumonia due to the child being recurrently exposed to the environment with sick context. So which is still possible. So if that's the thing, then child may come in with many episodes of pneumonia. Okay. Another question that you must ask is that if there is a problem with the child, okay, that is predisposing the child to present with recurrent pneumonia. Okay, so that is something to be looked into, because you may need to do further additional investigation to rule out underlying condition like primary immunodeficiency that is predisposing the child to develop recurrent pneumonia. Okay, if there's nothing wrong with the child shouldn't develop recurrent pneumonia unless the child is still going back to the same TASCA where the child frequently falling sick, getting sick contact. So every time there's a sick contact, some outbreak there, and then the child that gets a new infection. So in that case, the previous episodes might not be related to the current episodes, as in like there might not be any problem with the child, but you must always ask yourself, if the child is having any problem, underlying problem like primary immunodeficiency, some problem with the immune system that the child cannot mount immune response to fight the infection when there's exposure. So that has to be investigated. Okay, we won't go into that details because it's totally a different topic altogether. Okay, so one last question. All right, so if there's no other question, then we will move on to the last lecture.
Assalamualaikum and hi to Dr. Arunan and all colleagues. Can you guys hear my voice?
Yes.
And does the slides come out in your screen?
Yes.
Right. Okay. Thank you. My name is Muhammad Faris bin Abdul Ghani, matric number 2112879. And I will presenting about acute gastroenteritis or AGE and dehydration. Okay, this is the content of the what I will presenting today. The introduction, the etiology, the pathophysiological, the clinical presentation, physical findings, and the hydration, and also the complication, investigation, and management. So for introduction, AGE is inflammation of stomach and intestine that often defined as increased stool frequency with alteration in stool consistency, or we call another term is diarrhea, which increase in more than 3 loose or watery stools in 24 hours, or a number of loose or watery bowel movement that exceeds children's usual number of daily bowel movement. So this might be accompanied with vomiting or fever, and usually it will last than 1 week. So the main problem with acute diarrhea is ability to cause rapid fluid loss through stools. In addition to the patient might be also experience electrolyte loss. So the volume can vary from 5 milli per kilo body weight to 200 milli per kilo per body weight per day. So this is something we need to focus on, because it leading to childhood mobility and motility, and also we can cause dehydration and shock is the more, and that is the most frequent and dangerous complication to the children. So etiology, so it can be caused by virus, bacteria, for parasite. And for virus, it is the most common. It is the main cause of virus-induced gastroenteritis in both developed and developing countries. Other than that, we have adenovirus, norovirus, coronavirus, astrovirus, and pararotavirus. So for bacteria, we have enteroinvasive bloody diarrhea that cause bloody diarrhea, such as Campylobacter jejuni, the commonest, the Shigella, Salmonella, or enteropathogenic E. coli, Yersinia enterocolitica. So, and for parasite, the parasites that can cause AGE is Entamoeba stolica, Gardia lamblia, Cryptosporidium, and Cyclospora cyantensis. So in developed country, enteric virus are more important than bacterial pathogens in causing childhood diarrhea, while in developing countries, on the other hand, is caused by bacterial pathogens. So in Malaysia, major enteric virus causing childhood AGE is rotavirus and norovirus and enteric adenovirus. So for bacterial gastroenteritis, the most important causative agent is Salmonella, followed by Campylobacter, Shigella, and E. coli. So this is the percentage, the causative agent of the AGE. Generally, in patient with high, so question come up, how to differentiate between it is a virus or bacteria. So for generally in patient with high fever, more than 39 degrees, overt fecal blood with abdominal pain, central nervous system involvement, such as irritability, apathy, with seizures or coma. Usually we suggest it is due to bacterial. So while patient presenting with more significant vomiting and respiratory symptoms, we suggest it is from viral. So such as for rotavirus, causes more severe vomiting and dehydration. However, it should be emphasized that the clinical features of both viral and bacterial etiology may be overlap. So what is the pathophysiology of the AGE? So AGE is acquired maybe by person-to-person spread or ingestion of contaminated food or drinks. So when the children ingested the contaminated food, so there will be colonization of the gut by enteropathogens, which may cause clinical symptoms lah. So it will the diarrhea occurs when the intestinal fluid output overwhelms in the absorptive capacity of the gastrointestinal tract, and this can be identified by two mechanisms. The first mechanism is the damage of the villus brush border of the intestine, causing malabsorption of the intestinal contents and leading to osmotic diarrhea. Such as what happened to the lactose intolerance lah. So there is malabsorption of its content. While the other mechanism is release of the toxin that binds to the specific enterocyte receptors, causing release of chloride ions into the intestinal lumen and leading to secretory diarrhea. So when the pathogens is attached to the gut, there will be a secretory diarrhea and increase the and leads to release of the fluid. So the clinical presentation, so the most typical presentation is obviously diarrhea lah, and it will occurs in acute onset that lasts 5 to 7 days. The stool typically loose or watery, and it increase in frequency, the fluidity, the volume is more than normal, and the color might be greenish, mucus, there might be blood or musty color. So this might be due to invasive bacterial infection. And other clinical presentation would be vomiting, and it is acute in onset and usually lasts for 1 to 2 days. So other presentation can be fever, lethargy, dizziness, abdominal pain, headache, myalgia, and also reduce urine output. You may ask the mother, does their children reduce the usage of the pampers or reduce the food intake. So you also ask for the travel history and or exposure to unsafe food, which like raw food, uncooked meats or egg, and also from the farm animals. And also we ask for the social history. Other the patient might be come from the rural areas that no or less hygiene, food hygiene. So next, for physical findings, we from the general and inspection, general examination and inspection, we can see the pulse is rapid. There is tachycardia. We can see the eyes is sunken. The eyes is sunken. There is dry mouth, and also before that, reduced capillary refill time. The skin is turgor. There is also in infant. There might be sunken of anterior fontanelle, and also there is abnormal respiratory pattern, which indicates there is acidosis. And also there is restlessness or irritability to the children. And for palpation of the abdomen, the abdomen might be voluntary guarding if you touch the abdomen, and also there is tenderness, which disability is mild to moderate. So if you percuss the abdomen, there is the panic, and also if we auscultate, there is a gurgling bowel sound that highly suggests that it's diarrhea. So we go now into the sign of dehydration. Dehydration. So if patient comes to you or the clinic, so we should classify dehydration into the severity lah. So this is essential for appropriate fluid management. So the best measure of dehydration is by percentage loss of body weight, and the most useful signs of significant dehydration are prolonged capillary refill time, more than 2 seconds, reduced skin turgor, and also abnormal respiratory pattern. So we can see there is below there, if there is sign of dehydration, there will be reduce the body weight and 3 to 9% of the child, and also if severe, it deficit more than 9% of the body weight. Okay, so we need to classify the dehydration according to mild, moderate, or severe. Kalau macam mild, there is reduce the body weight 3 to 5% of the body weight, while moderate 9 to 6, and also severe is more than 10% of the body weight. So we I tell you before, We can see to the eyes in severe cases of dehydration, it will be grossly sunken, and the skin turgor will be tempting. The heart rate, there is tachycardia, there is hypotension, there is shock, and also there is the mental status will be depressed or lethargy or restlessness. The thirst we can see at the mouth mucosa, there will be dry. There indicates marked increase of very thirst lah. Like there is also absence of the tears. The patient might be the child might be crying, but there is no tears. And also the endocardial is markedly sunken and reduce delayed capillary refill, and also reduce in urine output. So we can see here in the picture sign of dehydration on infant. So for decreased urine output for infants baby, that indicates by no wet diapers in 6 to 8 hours. So we can ask the mother how many times did her change her diapers, and also once he in the diapers, how long the diapers is unchanged. So for toddlers or older children, we see the very little dark or yellow urine. It indicates there is loss or less urine output lah. So we can see in this picture also for skin decrease in skin turgor with pinch, the skin will be delayed in to return to its origin shape. The sunken eye, the eye will look sunken deeply, and there is dry mouth, and there is also sunken of anterior frontal. So for the complication, there will be 3 complications which is to renal, to CNS, and to GIT. For renal, there will be oliguria which less than 200 ml per cube per day. That will also can cause acute injury to the child. There is also hypovolemic shock due to dehydration. There will be electrolyte imbalance, hyponatremia, hypokalemia, and metabolic acidosis. This also come out with they also caused by the profuse diarrhea and also vomiting, and also hemolytic uremic syndrome, which acute of onset of microangiopathic hemolytic anemia. It can also thrombocytopenia, acute renal impairment, and also hemorrhagic colitis by dysentery, and also E. coli. It can cause also to a complication to CNS, which convulsion, which might be caused by hyponatremia, hypoglycemia, febrile convulsion, and cerebral hemorrhage. For GIT also, there will be prolonged diarrhea, which more than 14, which complication to the GIT if the patient had prolonged diarrhea, which more than 14 days. So for investigation, in majority of children with uncompleted AGE with no sign of dehydration, laboratory investigation are unnecessary. But this can be if the symptoms, the acute diarrhea or vomiting, the symptoms occurs acute less than 5 days, no non-bloody diarrhea, no exposure to cases of bacterial enteritis, so no intervention required, just just by increase the fluid intake lah. So if there is fever or there is blood and mucus in stool or without toxic appearance, So we do stool culture to identify whether there is Salmonella, Shigella, and this bacteria. And also if there is a toxic looking ill appearance, we do CBC, we do urine analysis, creatinine urine analysis, and also we took the stool sample. If the patient had a bloody diarrhea, severe watery stool, or severe prolonged diarrhea, or in patient with immune compromised children. So we do also in to culture, and also to the abdominal X-ray if the patient had toxic megacolon perforated, there is perforation. We do also abdominal ultrasound if there is caused by surgical causes, which is interception. And also we take glucose, blood glucose. There is because in patient who had severe diarrhea, there is hypoglycemia.
Okay, this shouldn't be treated as a checklist. This shouldn't be treated as a checklist. Every investigation that you would like to consider should be individualized to that particular patient based on the history, physical examination finding, and your provisional diagnosis. Okay, not necessarily as long as once the patient come with diarrhea and patient is looking toxic looking and ill appearing, that doesn't mean that the child should get all this until the abdominal X-ray or abdominal ultrasound, glucose, and all that. So it's as I say, it's individualized. You must look at what is your patient is having, what is the provisional diagnosis. So the investigation should match your diagnosis and the patient's condition. Of course, these are the set of investigation that you can consider. Okay, you have to keep in your mind to choose from. Okay, depending on your patient's condition. Okay, continue.
Okay, thank you, doctor. So this is the differential diagnosis of the AGE. First is system infection, which is septicemia and meningitis. But we should, it is we always need to always keep in mind that possibly that the diagnosis of AGE might be incorrect. So although the AGE consists of the triad of vomiting, diarrhea, and fever, the condition and the condition can also present with the above symptom as well. So these are the differential diagnosis that might be occurs that might be manifested to the children, same as well as AGE lah. So first is system infection such as septicemia and meningitis, local infection, respiratory infection, UTI, might be from surgical causes such as pyloric stenosis or interstitial, or also appendicitis if the patient come with the severe abdominal pain, and also fever, and also vomiting, and also such as metabolic disorder with altered or respiratory pattern altered, and also with acidosis presentation, vomiting, and severe hypoglycemic and manifestation, and also for renal disorder such as hemolytic uremic syndrome, and other such as celiac disease or lactose intolerance or cow's milk protein intolerance. Okay, next for the management. We assess the patient according to the individual manifestation to the children lah. So if the patient is a general condition is well, alert, no manifestation of no signs of dehydration, no sunken eye, can drink normally, and the skin is not turgor, and there is might be mild dehydration. So we go to plan A. So I will discuss further on plan A, plan B, plan C in next slide. And also if the patient generally make irritable, restlessness, there is degree of sunken of the eyes, there is thirstiness, and also drinks eagerly if the patient given drinks. There is also mild skin turgor and also dehydration. There is moderate hydration, we go to plan B. And if the patient is in severe condition with a manifestation signs of dehydration, we go and there is say apa ni, there is the patient is unconscious, we go to the plan C. So next, so what is plan A, plan B, plan C? Okay, plan A, we can treat it at home. We just give the extra fluid. If the patient is infant, we give just breastfeed regularly or give ORS. Continue feeding and oral fluid. And also if the patient getting worse, apa ni, we come to the emergency or back to the hospital. So for the plan B, use oral rehydration by giving the patient more fluid, or give ORS for 4 hours period. We also, if the patient cannot tolerate by drinks by himself, we can give nasogastric rehydration by the nasogastric tube. Also, we can apa ni, attach IV fluid or admit if not tolerate. So below that is the amount of ORS to be given for the first 4 hours according to the weight of the infant, weight of the children. So the plan C, if there is severe dehydration and also there is shock, so we assess the ABC, the airways, the breathing, the circulation, and we start IV fluid immediately. And also we assess children hydration status every 1 to 2 hours. So we all these measures, we admit and monitor the vitals, the vitals, and if they
No. Apa dia cakap tadi?
Apa?
Differential diagnosis.
Differential diagnosis. Laptop share.
of cases lah. So in drug therapy is unnecessary in most cases, and might be even considered dangerous. So with only a few exceptions lah. Yeah, if we ask ourselves, should we give the antibiotic to the children? So antibiotic therapy should not be given routinely in children with diarrhea. Such therapy is ineffective and might be harmful. Majority of AGE cases in children are viral in origin, such as come from rotavirus, norovirus, or adenovirus. So antibiotics are only needed for specific pathogens or defined clinically settings, like such as Shigella, dysentery, or cholera. So antiemetics also include such as antiemetics also we don't prescribe to the patient. This might be cause sedation that can interfere with the oral rehydration therapy. Due to its reason, antiemetics are not routinely indicated. So antiemetics may decrease vomiting but increase frequency in diarrhea. So this will lead to retention of weight and toxin that would have been eliminated through vomiting. Therefore, it is recommended that children with persistent vomiting should be given small frequent feeds. So for infant, we should encourage the patient to get more breastfeeding lah. because it's the best measure for the prevention of AGE in young infants. Last one is indication for hospital admission. If the patient is severely shocked or dehydration and persistent or bilious vomiting, if there is no dehydration, and also if we give ORS but not the ORS is not compliant, there is clinical deterioration, or there is neurological abnormalities such as lethargic seizures, we need to bring the patient to the hospital immediately. And patient factor, the patient might be have underlying medical conditions such as heart disease or etc. And the caregiver not able to provide sufficient care at home. Age appropriate diet recommended after rehydration. The patient should be that's why we have to assess the weight of the patient, so we can bring the appropriate diet to recovery. And antibiotics is not used routinely, only helpful in cases of bloody diarrhea and suspected cholera with severe dehydration. And also this is antidiarrheal medication are not routinely suggest. So we give also zinc supplements recommended during acute episode of diarrhea for children above 6 months and above. So in the patient, in the areas with high prevalence of zinc deficiency and malnutrition, such as in the rural areas. I think that is all from me. Thank you.
I have a question. What is the difference between AGE and food poisoning?
AGE and food poisoning. I think food poisoning, I think, if I'm not mistaken lah, I think it is the same. AGE is diagnosis. I think AGE is food poisoning, if I'm not mistaken lah. Doctor can correct me if I'm wrong.
Okay. AGE is the umbrella term. Okay, so the etiology, as you mentioned in your lecture, it can vary from viral, bacteria, protozoal, parasite, all kind of organism. Whereas food poisoning is a specific term under the umbrella term of AGE. Okay, meaning you are narrowing down your symptoms to a specific mode of transmission and a specific etiological agent. So food poisoning most of the time is caused by bacterial causes, isn't it?
Yes.
Right. So most of the time, food poisoning is caused by bacterial agents. Okay, and you know the mode of transmission is by from the food. Right. So I hope let's make that answers your question. Yeah. Okay. Anything else? Ada soalan lagi? Okay, if there's no more question, thanks for the effort and presentation. Okay. We will end here. Thank you.
Thank you, Dr. Arunan.
Thank you,
Thank you,
Doctor.
Thank you very much, Doctor.
Thank you, Doctor.
Thank you, Doctor. Thank you, Doctor.
Oi, tak live lagi ke? Oi.